Hello, I'm Dr. Vicki Wheelock. I'm the director of the HDSA Center of Excellence at UC Davis Medical Center in Sacramento, California. I'll be discussing motor dysfunction and neurological care in Huntington's disease. These are my disclosures. These are the learning objectives for this module. Huntington's disease has a differential presentation with age. Juvenile onset motor features include rigidity, bradykinesia, and dystonia, but typically not chorea. Adult onset motor features include chorea and hyperkinetic movements, as well as a rigid dystonic presentation in 10% of patients. The effect of the disease in both populations, though, does result in progressive slowness of movement, loss of voluntary control of movement, rigidity, and dystonia in the late stages. If we look at this graphically, you'll see that patients who have juvenile onset Huntington's disease tend to have more rigidity, dystonia, bradykinesia. Adults who have Huntington's disease tend to present with chorea and hyperkinetic movement disorders. Over time, the symptoms begin to progress to more bradykinetic and rigid dystonic features. Chorea is an involuntary movement with sudden, irregular, purposeless features. Nearly all adults with Huntington's disease experience chorea. It's often more prominent distally in the fingers and toes, but it can affect the face and other body parts. Chorea can be voluntarily suppressed for short periods of time. The amplitude and frequency can change under different circumstances. Some patients may be unable to tolerate chorea because of social embarrassment, but others may be somewhat unaware of it. Chorea can affect sleep as well. It's important when doing the neurological examination to pay attention to abnormal involuntary movements that occur while taking the history. They can be picked up more easily during examination by asking the patient to relax and by giving them a mental distraction task, such as closing their eyes and counting backwards. Correlates of chorea include motor impersistence, the inability to maintain a particular posture, and involuntary other movements. This is an EMG recording from the surface of the muscles of a patient with early Huntington's disease. This demonstrates the choreiform movements. The choreiform movements cause brief bursts of muscle activity with pauses. They're irregular, they vary in duration, and they vary in amplitude. This surface EMG recording demonstrates motor impersistence. The patient is asked to maintain a particular position, and there are bursts and pauses of activity which the patient cannot control. Chorea can be quantified using the Unified Huntington's Disease Rating Scale. The UHDRS was developed to quantify various features of Huntington's disease. The chorea subscore is displayed in this slide. There are 7 body regions that are evaluated for chorea: the face, the buccal orolingual region, the trunk, both arms, and both legs. The severity scale ranges from 0, which is absent, mild, slight intermittent chorea, mild, common, or moderate intermittent chorea, persistent chorea, and marked or prolonged chorea. Each body region is assigned a score, and the chorea subscore is the summation of the 7 individual scores. This is an example of a patient with chorea. Management of chorea starts with behavioral and non-pharmacologic treatment. Chorea can be worsened by stress, anxiety, and mood disorders, which are very common in Huntington's disease. Identifying and treating those issues can help reduce chorea significantly. We also recommend using schedules and routines which help the person with Huntington's manage their behavioral and motor function. We tell patients and families to allow extra time to complete tasks. When chorea is very severe, we might recommend using padding or other sorts of adaptive bedding to help reduce injury. Pharmacologic treatment of Huntington's disease-associated chorea is available, and we'll discuss the drugs in just a moment. This is a list of potential indications for starting anti-chorea therapy. For instance, for some patients, chorea will interfere with sleep. They may develop muscle pain. They may have injuries of their limbs because of striking things in the environment. They may start to have falls if they have truncal or leg chorea. In general, patients who have a chorea score of 8 on the Unified Huntington's Disease Rating Scale should be considered for pharmacologic treatment. Pharmacologic management of chorea can often start with a simple dose of benzodiazepine at bedtime for patients who are having difficulty falling asleep or maintaining sleep because of chorea, but who don't have significant daytime symptoms. For patients who have significant daytime symptoms of chorea, anti-chorea therapy starts with tetrabenazine, which was approved by the FDA for Huntington's disease-related chorea in 2008. The mechanism of action of tetrabenazine is to prevent the presynaptic release of dopamine within the striatum. In a randomized controlled study performed by the Huntington Study Group, tetrabenazine was found to be very effective as anti-chorea therapy, reducing the total UHDRS chorea score by 5 points versus a reduction of only 1.5 points in the placebo group. There are specific safety considerations for the use of tetrabenazine. There's a black box warning about the risk of suicidality and increased depression in patients with Huntington's disease. Patients who have significant depression, a history of suicidal ideation, or unstable psychiatric symptoms are not good candidates for tetrabenazine therapy. Patients on MAO inhibitors are also not good candidates for tetrabenazine therapy. Tetrabenazine is metabolized by the CYP2D6 system. Patients who are on high doses of strong inhibitors of CYP2D6 will have higher plasma levels of the drug. Other side effects include sedation and possible prolongation of the QTc. It's advisable to get a baseline EKG and to be cautious about prescribing tetrabenazine in patients taking other drugs that can prolong the QTc interval. Tetrabenazine is not available through local pharmacies. It's supplied through a mail-order pharmacy using a process that helps to ensure patient access. The dosing of tetrabenazine is the same as it is for many other drugs. Start low and go slow. The initial dose is 12.5 milligrams daily. You can increase the dose by 12.5 milligrams each week, and monitoring patients for the beneficial effect of reducing chorea and also monitoring closely for side effects. Patients who require doses higher than 50 milligrams per day to reduce chorea should have CYP2D6 genotyping in order to learn if they are fast or slow metabolizers in order to help guide the dosing. There are alternatives to tetrabenazine for chorea control. For patients who would not be good candidates for tetrabenazine, we often use neuroleptic drugs off-label to help reduce chorea. The mechanism of action of neuroleptic drugs is to blockade the striatal postsynaptic dopamine receptors. Typical neuroleptics and atypical neuroleptics are both used. Side effects of neuroleptics include sedation, restlessness, and the possibility of tardive movement disorders. Atypical neuroleptic drugs have additional risks of causing metabolic syndrome with hyperglycemia, hyperlipidemia, and insulin resistance. Anti-chorea therapy must be evaluated at least annually after initial dose optimization. Some patients may require higher doses as the chorea escalates. Most patients, however, will develop rigidity, dystonia, bradykinesia, and when these symptoms predominate, anti-chorea therapy needs to be reduced. Another movement disorder commonly seen in Huntington's disease is dystonia, which is an abnormal repetitive pattern of muscle contraction, often with a twisting quality. Common examples in Huntington's would be dystonic arm elevation while walking, grinding of the teeth, and elevation and twisting of the foot while walking. Dystonia often emerges in middle or late stage Huntington's disease. But remember that 10% of adults with Huntington's disease present with rigid dystonic symptoms. The management of dystonia in Huntington's disease is similar to the management in other conditions. We often use botulinum toxin injections for focal regions affected by dystonia, benzodiazepines. We will sometimes use Parkinson-related medications such as amantadine and carbidopa-levodopa, including occasionally dopamine agonists to help treat the rigidity and dystonia. Bradykinesia is the slowness of voluntary movement that we see in Huntington's disease. It's very common, it's inevitable in fact. Bradykinesia often begins to appear in the middle or later stages of Huntington's disease, but it can be seen in early stage HD, typically with masked facies. Bradykinesia will become more and more disabling as the disease progresses, and anti-chorea therapy can sometimes worsen bradykinesia. The management of bradykinesia is to reduce anti-chorea therapy and to use careful doses of amantadine or other medications. Bradykinesia is one of the major causes of disability in Huntington's disease. Other movement disorders can also appear in Huntington's disease. Myoclonus and tremor are common in juvenile Huntington's disease. Myoclonus consists of brief, shock-like movements that affect the limbs or the trunk. Tremor is more rhythmic and oscillatory. Myoclonus can be effectively treated with clonazepam and benzodiazepines. Tremor can be treated by using anti-Parkinsonian drugs, but it's important to recognize that tremor can also emerge as a side effect of neuroleptic treatment. In those cases, neuroleptic treatment will need to be reduced. Tics can be either motor tics or vocal tics. They can sometimes be treated with botulinum toxin or with neuroleptic medications. Rigidity is more common in juveniles and adults with the rigid dystonic form of Huntington's disease. Treatment includes reduction of the anti-chorea therapy if present, the use of benzodiazepines, and the use of splinting and other assistive devices. Gait impairment and falls are significant considerations in patients with Huntington's disease. These typically emerge in middle or late stage Huntington's, but occasionally will be a presenting feature. The gait is typically slow and wide-based in Huntington's disease. Postural reflexes are impaired so that falls can occur more easily if the center of gravity is perturbed. Chorea of the trunk and lower limbs can also contribute to falling, and anti-chorea therapy will help to reduce falls in these cases. Management of gait and balance problems includes an early referral to a physical therapist who can do a gait analysis and teach the patient adaptive strategies, balance exercises, fall prevention, and can prescribe the specific equipment needed to help reduce falls. Wheelchairs will become necessary in late-stage Huntington's disease. Custom wheelchairs are often necessary because of the need for reclining back, removable armrests, removable leg rests. Here are some examples of equipment that can be used for Huntington's disease. In some patients, a deluxe four-wheeled walker will help in the earlier stages. There are lightweight collapsible wheelchairs to be used for community mobility, and in late-stage disease, chairs that have protective padding and allow change of body position are very helpful. Speech impairment is also common in Huntington's disease. The rhythm and speed of speech are affected, and the articulation is affected as well. Patients may develop a soft hypophonic voice. They may have difficulty coordinating speaking and breathing. There can be significant delays in answering questions, partly because of bradykinesia and also because of slowness of cognitive processes. We refer early referral to a speech therapist for patients with Huntington's disease who have significant speech difficulties. The speech therapist can help the patient do exercises that will help to improve their articulation. They can help the patient develop strategies to improve communication, and they can also prescribe specific communication assistance devices if needed. It's important to remember that cognitive challenges in Huntington's also contribute to speech impairment, and treatment of those cognitive challenges can also help communication. Patients with Huntington's disease are prone to having difficulty swallowing and choking is probably one of the greatest fears of the patient with Huntington's disease. The swallowing difficulties are related to impaired voluntary movement. There's slowness of chewing, slowness of moving a food bolus to the back of the throat, slowness and incoordination of the swallow mechanism. Patients with HD can have difficulty with choking on liquids or solid foods. Frequent choking can lead to weight loss and dehydration. It can also lead to aspiration pneumonia. The management is with early referral to a speech therapist who can perform a formal swallow evaluation to help advise the patient and caregiver about strategies to avoid choking. Changes in the textures and types of food can often be extremely helpful. Family members should be educated about strategies to help the patient reduce choking. For patients with severe swallow problems, weight loss, and difficulty with dehydration, feeding tubes may be an option. Another neurological feature of HD are seizures. Seizures can occur in up to 30% of children with juvenile Huntington's disease. They're much more rare in adults with HD. The standard neurological workup, including neuroimaging and EEG, is indicated. Treatment will be guided by the type of seizure and by concomitant medications. Weight loss is a very significant problem in HD. It typically appears in the middle and later stages. Weight loss is multifactorial. There are increased metabolic demands because of chorea. Difficulty with executive function can lead the person with HD to forget to eat or to forget to complete their meals. And swallow dysfunction can also contribute to weight loss. The management of weight loss in Huntington's disease involves identifying the specific cause. If chorea is problematic, anti-chorea therapy will often help to reduce weight loss. Using schedules, structure, and reminders to help the person eat, and as well as helping out with meal preparation and access to food, can be very helpful. Patients with HD may need assistance in feeding. We also recommend dietary referral for some patients who will require very high-calorie diets to help maintain their weight. Incontinence and urinary retention are also potential features of Huntington's disease. Bladder and bowel incontinence are more common in the later stages. Most of our knowledge about this is anecdotal. Causes could be related to dysexecutive function with lack of recognition and unawareness of the need to void or to have a bowel movement. Sometimes apathy or other sorts of mood disorders can also contribute. Some medications may have side effects that are anticholinergic and can cause urinary retention and constipation. Urinary retention is not uncommon in Huntington's disease in our experience. The management is to help schedule the patient to go to the bathroom regularly, to identify medications that may be contributing to urinary retention or constipation, and to refer to urogynecology or urology for patients who seem to have symptoms of retention or difficulty with emptying their bladder. Pain in Huntington's disease is a complex topic. Patients may fail to recognize or report pain, and yet we sometimes see people who have conditions such as injuries from chorea or falls or even urinary retention who obviously must be experiencing pain. It's a challenge both to the family and to healthcare providers to identify pain and to manage it. Sometimes pain will produce behavioral problems such as agitation, irritation, yelling, anger. Pain is expected in the later stages of Huntington's disease and needs to be managed for every patient with late-stage HD. It's important to have medication ordered for the patient to help reduce the pain of immobility, to help to perform range of motion exercises, to have adequate bedding and padding, and to assess the patient for possible pain. Take-home points. Most adults with HD manifest chorea, but juveniles and 10% of adults have a rigid dystonic presentation without chorea. The Unified Huntington's Disease Rating Scale, chorea rating scale, is a validated tool that's useful for evaluating the severity of chorea. Behavioral strategies and pharmacologic approaches are effective for managing chorea. Pharmacologic treatment must be monitored and reevaluated at least annually. Monitor and treat HD patients for other features of motor impairment, especially dystonia, bradykinesia, and dysphagia. Monitor and treat HD patients for other neurological impairments, especially weight loss and pain.